Hello, everybody, and welcome to tonight's webcast, which is called Going Deep and Wide on Specialty Contact Lenses. I'm Ted Newell. I'm the moderator this evening. And this webcast was sort of born out of the recent GSLS meeting in Las Vegas. Um, we had a really good program there that was 2 hours long, which I think most of you would agree is a little bit long for an evening. So we divided it into two evenings so people can choose to come to both or come to the section that's most interesting to them. So we're talking about a bunch of case studies tonight related to the eye surface profiler. And for those of most of you know a little bit about the eye surface profiler, or you probably wouldn't be here. But essentially, what we're doing is we're applying a fluorescein coating on a nice lubricating drop that has hyaluronic acid onto the eye, and that gives us a reflection of data via Fourier transformation, and we get height data, and we convert that height data into very accurate 3D maps. And for any of you that have seen the software, you know that we have numerous images and maps that you can use as you're trying to design a lens. So that's the way the technology works in very general terms. But what we're trying to do overall is streamline the fitting process. So we're helping you take a scan. Our software is helping you to analyze the 3D eye data. And then we've worked with numerous labs to come up with these lens fitting algorithms, and we call them first lens fit. And then we also work with the labs to create an ordering system so that we can help you order the lens of your choice, efficiently. So that's what we're trying to do, not just with the instrument, but we're trying to do that with the software. We're trying to help with the entire fitting process. Okay, so again, deep and wide. Tonight we're going to focus mostly on the scleral lens side of the subject matter, the cases, and also hybrid lenses. And then tomorrow night we go into OrthoK, soft, and GP. And this is just an example when we talk about all the different companies that we connect with, that we work with for creating the algorithms to create the first lens fit, to create those prescription forms. We have over on the left-hand side many of the scleral companies. On the right-hand side, you can see the OrthoK, RGP, soft, and hybrid. And we're adding labs all the time and adding lens designs. And when one of the companies tweaks a lens design, well, we've got to get to work with them to add it to our system. And that's happening all the time. We have upgrades probably twice a year. So tonight we're really privileged to have three speakers in this part of the webcast to help us out with our technology and also their great clinical skills that you'll see demonstrated in these case studies. We've got Dr. Langis Michaud. He graduated from l'École d'Optométrie de l'Université de Montréal, where he also obtained his master's degree in psychological optics, or I should say physiological optics. He is a full professor and has practiced at the Université de Montréal since 2001 as the chief of the contact lens department. And for more than 10 years, he was a visiting professor at the Université de Paris Sud in France. Dr. Sheila Morrison earned her Doctor of Optometry and completed a master's degree in vision science with a focus on scleral lenses, along with a residency in cornea and contact lenses from Pacific University College of Optometry. She served on the faculty at the University of Houston College of Optometry, facilitating education and research in the contact lens and cornea service. And she's also an adjunct faculty at the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. Dr. Aaron Wolf received his Doctor of Optometry degree from the University of Houston. He is the owner of Austin Optometry Group, a private practice in Austin, Texas, focusing on ocular surface disease, and specialty contact lenses, including scleral lenses and orthokeratology. Dr. Wolf has served as a product development consultant, IRB research participant, and a key opinion leader for numerous anterior surface imaging manufacturers and specialty contact lens manufacturers. One note I should say about Dr. Morrison is she is at Mission Eye Care in Calgary, Canada. Now, all three of these talented individuals have published numerous articles in peer-reviewed journals and publications and are frequent presenters at conferences worldwide. So with that, we will get started with Dr. Langis Michaud.
Thank you, everybody, to join this webinar about the use of eaglet as an essential tool in our clinical practice more and more when we want to fit specialty contact lenses. The first case I want to discuss with you or to share with you is concerning post-Lasik ectasia. We have a patient here of 42 years old. I met recently at the School of Optometry, University of Montreal. He had been wearing soft lenses for the last 20 years, and he was complaining, as many other practitioners, but patients, I would say, of discomfort at the end of the day. He had LASIK 3 years ago because of the discomfort provided by contact lenses. And unfortunately, he was bearing a first keratoconus that was not detected at the time of the surgery. Obviously, because of that, he developed post-Lasik ectasia, more on the right than the left eye, but both eyes are affected. And obviously, his ocular dryness didn't improve after the surgery. To the contrary, it became worse. After discussion about what are the options offered to him in order to improve his condition, we decided to fit him in scleral lenses, not only to restore the visual acuity caused by the ectasia, but also to contribute in part at the treatment of his eye dryness. So here's the map we had from him. You see the keratoconus, the first keratoconus, which is bulging on the inferior part of the cornea. Transition between the limbus and the conjunctiva is a little bit asymmetrical, as we can imagine. You see larger areas of red color compared to a thinner ones. And you see that on the blue part in the conjunctiva, you see where the conjunctiva is deeper in depth, and obviously we immediately see that there's an irregularity in the conjunctival profile. For clinician, what this map is telling us is you will have to customize your fit in order to be efficient. Otherwise, you will have a misalignment in one of the quadrant, and that may create problem, either compression, where you are too much aligned, or to leave a gap where the particles can enter, and because of the suction effect, because of the subatmospheric pressure under the lens, debris will accumulate, and we may have midday fogging issue with that kind of fitting. So that kind of information to start with is very, very important to know, because instead of driving in a fog condition in an unknown road, we know exactly where to go. We have a GPS in front of us, and we are quite sure to get to the point very rapidly, very efficiently. So the software allows us also with color maps to analyze the different profile. We see here at the limbus junction, I already mentioned that we have some sort of irregularity, and you will need to adapt this kind of transition in the lens. In that particular case, we work with the Zen lens from Bosch and Lomb. Why? Because it offers us, this possibility and this option to have a bioelevation, addressing these irregularities and this mismatching of the junction at the limbal vessel, and certainly to kind of share the toricity between the conjunctiva and the vaulting chamber, which is really just on top of the limbal area. So separating these two entities and sharing the overall toricity help us to design lenses that are less complicated and more equilibrated, better centered, and obviously the vision will be at the end better because the lens is less decentered. We are better aligned in every quadrant, and the tear reservoir under the lens is more uniform also, which also contribute to the beauty of the scleral lens vision provided by scleral lenses. So in that case, in the one side of the lens, we have you see some differences between minus 100 microns and plus 100 microns. When you deal with eaglet software, the software can really suggest the first lens to try. That doesn't mean it's the final lens to order, of course, but it gives you a very good idea of, where to go in order of, putting the first lens on that eye. For the patient, it's a better experience because you are close to what you need as a final product. It's a better experience, better comfort, better stability, and the patient feels almost immediately what will be the outcome with the final lens that you will generate with the help of this software and your own observation under the slit lamp also. The sag was minimal, 4450, and the on the other eye 47 48. So again by elevation in that side, with the targets to vault by 225 and 300 microns, no more than 300 microns over the cornea. And we know how challenging it is, especially when we have a severe keratoconus, to vault minimally over the cone, never touching the cornea, and vaulting symmetrically with other parts of the cornea, especially the superior cornea where the cornea is flatter. Then you may have an excess and an overvault in that particular area. So that kind of bi-elevation help you to limit that kind of issue. And we see the profile here of what a bi-elevation lens gives you instead of a regular one. So you can really adapt this transition over the limbal area where the vaulting chamber is to determine and to share the toricity from the conjunctiva and the inner portion of the lens. So in that case, we decided to go with a larger lens, 17 millimeter, because of the size of the cornea, and because of the dryness of the eye. When you treat eye dryness, you need a larger lens in order to vault and to cover most of the area that is exposed to atmosphere, air, and with the eyes open. So the 17 millimeter was selected. So as a take-home message in that case, eaglet eye allow us to look at the entire anterior surface in just one click. So it's not a multiple scans. We do it just one scan, and the quality of the scan is very important. So there's a learning curve there. Obviously, the first scans you'll do will have to be improved, of course, as it is for any other machinery that you have in your office, but very rapidly you will be able to produce very good quality images, and from there to translate that into your diagnostic lens trials. And you can even send your maps directly to the lab and with the consultant determine what is the best option for that particular patient. And that's the case in a very challenging surface where we have a lot of things to do, and we have a second case that will be exactly like that. So we have the possibility to analyze which lens we will have to adapt. We can identify really at the upfront where are the hot spots. So when I sit the patient in front of the slit lamp, I know exactly where I have to make sure to evaluate my lens fit and my lens to cornea relationship, because I know exactly where are the weakest spot of that surface. So it saved me chair time, in fact, doing that, because I know exactly where the troubles may arise in the future. Obviously, to have lens fit suggestion is helpful. It saved me time again, as here at the school, we teach our students how to fit lenses. So it really helped me to explain why this lens was selected based on the parameters we see on the software and given by the software and by the machine and by the map, of course. And it helped my students to understand better the relationship between a scleral lens and a cornea. It doesn't preclude your own evaluation under the slit lamp, of course, and doesn't preclude also to consult the lab consultant, as I mentioned, but you can certainly have both of the best of both worlds, meaning you have a lot of information to share with consultant, because if you just take the phone and call the lab and say, hey, by the way, I have this patient that does something, you have no imagery, you have no photos, no fluorescent pattern, no maps to work with, The poor consultant at the other hand of the phone, just guess as you would guess in your own mind. But if you can rely on these data and you can provide some other imageries, photos taken under the slit lamp, for example, then the consultant has everything in hand to work with you in order to have a better outcome. At the end, you save your chair time, you save the number of visits for patients, and you save a lot of money to everybody. So that everybody's happy at the end of the day. And really, this software makes complicated case and your life easier.
Next, I get to sneak in and share a case that's really kind of hot on the trending list of all scleral fitting today. I have a patient that I want to share the journey of fitting HOA optics. It's kind of a thing that has been gaining popularity. We first started learning a little bit about HOA correction, I would say probably, I don't know, as early as maybe 10 years ago, maybe a little earlier. And the challenge when trying to get the optic into from an academic setting has always been that translating an aberrometry scan into a scleral lens. It's hard. The lens fit is really, really, really important in that number one, we need to have a stable device. Scleral is the best thing on the market that can actually accommodate that need for stability in a contact lens so that HOA optic can be placed precisely in front of the pupil and over the visual axis. Over the last couple, probably 5 to 10 years, we've seen big advancements to the point where we are now, where we have tools on the market that allow us to really smoothly evaluate and fit HOA optics on our patients. I want to share a case of a 32-year-old software developer. Now, this is our typical engineer brain. These people are usually, or this patient in particular, very detailed, had a history of PRK, so didn't really want to be in contacts at all, but had regressed. And so begrudgingly went back into contact lenses, absolutely didn't want to wear glasses for two reasons. One is not wanting to have glasses on, of course. That's why people have refractive surgery in the first place. And two is the quality of the optic that he got was better in contact lenses. Now, the patient still suffered from 20 unhappy vision. So clear cornea, no scarring, which are, on the more optimal versus contraindication side of patients who are good candidates for HOA optics. So again, they have usually clear corneas are best without a lot of central scarring, and capable of fairly good vision, honestly, but have that complaint of sort of 20 unhappy. Our engineers are really, and software developer in this case, is very detailed personalities often will really complain about this. And so this guy had, regressed to not a super high prescription, but just enough that he had to wear something full time and was not successful in clearing his monocular ghosting with any prior contact lens fits. We tried fitting him in 2021 with an optic that was fairly successful, utilizing fairly high level of optic and really nice design and a scleral lens that was very stable, but did not have HOA correction in it yet. And the patient had the best vision he had ever had since his regressed refractive surgery, but really just was still not happy. Had kind of like a hook-shaped ghost. Patients will notice this often when they're driving at night, because the pupil will then get bigger and darker illumination, and that really kind of is a window for the aberration from refractive surgery or other corneal irregularities to kind of get right into the vision. And so we decided to try a new tech. The way that it works in our clinic today is that whenever we have a patient in for any contact lens fit, any specialty fit, I should clarify, is we do comprehensive ocular surface mapping. And that's what you see here. So we have corneo-scleral profilometry as one of the measurements to allow us to really understand ocular shape from all the way inside, all the way out to where we may consider fitting a scleral lens. ESP can measure the cornea and the scleral. This is a comprehensive eye map. And you can see in this bisphere elevation map of the right and left eye that the patient has central flattening from his refractive surgery, was a prior -2-ish. So not super dramatic, but just enough that has that flattened tabletop shape. And his sclera, not crazy irregular. So he's a pretty good candidate for any kind of shape of, he could wear a freeform. He could more than likely wear a standard haptic that, would be fairly successful either with a low toric or spherical shape. We did decide, though, to put him into more of a premier lens. And the reason for that is because we wanted to make sure that we had a design picked that had the ability to accommodate HOA correction in it. And so we took these beautiful maps, and I have to say, data in equals data out. So we want to make sure with any mapping that we do for contact lenses of any modality with any topographer that what we're sending in for empirical design is high quality. There are measures within the software and the ESP that we use that I've trained my staff to use to look to see, how is the coverage? Do we have movement? What is the quality of the data? And is it centered? Is it aligned the way that it should be? If all of those things are yes, within reason, then we can send these beautiful maps in utilizing digital software. Now, Boston Site Scleral Smart 360 does have the ability to put HOA correction into scleral lenses. Now, in this case, data was really nice. We achieved a very appropriate first fit with no modifications on the shape of the lens on the first round. And it's very simple to use the software. It's literally, you select your map, upload it, and then it will take you, in this particular manufacturer's case, to a secondary site where you can, adjust your own lens. You can also click and make a note that I would like our consultation to design this lens for me. It's the full range. You take full control or you fiddle with it a little bit or have somebody else help design. It's all okay. All is going to get you to the finish line. Now, our Fit Connect, as I mentioned, gave us a first lens that was very appropriate on the first round. And I want to talk a little bit in my next case that I'll present just about why it's so important today in the market that we are to really optimize our time. When we spend time with patients, it's limited. Chair time is gold. And, we can spend a whole bunch of time sometimes adjusting lenses. And when there are ways that we just don't have to do that, that's the path that we should be taking. When we measure a patient for HOA correction, before we get a lens that is called the HOA lens, we would get a best fit standard kind of single vision lens. So no multifocal optic in it. Could be toric, that's fine too, but the best distance correction that's possible for this patient. So that's what we got, best first lens. And in the clinic, we actually take a measurement before we order an HOA lens. And the purpose of doing that is to kind of determine if a patient is a good or bad candidate for HOA correction at all. Some patients will complain about a ghost and it just really, the answer is not HOA. Maybe the answer is, something else that's going on, something about their ocular surface or a bit of a cataract or whatever it is. We need to also make sure that before we go ahead and upgrade patients into a lens that is more costly in most cases, in all cases, actually, a little bit more sophisticated, that we're likely to have success. So we do a measurement and I'll show you what those measurements look like in a slide or two, just so that you can see our process for how we fit. Once we determine a patient's a great candidate for HOA, then we get in these babies. So we see a right and left lens. These lenses are dotted. And the reason that they're dotted is because anytime we place HOA correction on top of the visual axis, if it's not just absolutely perfectly placed, we can actually induce more aberration and cause more dissatisfaction with our patients. And so these dotted lenses, they can, each manufacturer that can make or can apply HOA correction to sclerals has a slightly different pattern. But we received these in on our lenses that are previously fit for that perfect, stable fit, best distance vision. And then we take an OVID scan, in this case, on top. That's the unit that we use, and send the data into the manufacturer on top of this dotted lens so that they can identify and pinpoint exactly where the aberrations are and develop the optic that can neutralize it all. Here's a video to just kind of highlight and sort of brag a little bit about this first lens fit. And it's not always perfect. I know in a perfect world, everything would be perfect, but it just isn't like that. It makes us appreciate, though, when we do have the cases that just pop right in with these beautiful edges, well-centered. And again, I have to attribute the quality of the scan at this point, the age that we are today with digital design. Our labs do a wonderful job of turning data into lenses. And still there can be a bit of a gap in, well, it doesn't translate into a lens. And if you go back and look at your original scan, sometimes that can actually be the most important culprit or opportunity for us to really optimize the first lens fit. And so again, beautiful lens, dotted lenses, HOA scans on top. And I want to share a little bit about what our output looks like. And as I mentioned before, on our first lens, what we do is, even before we get those dotted lenses in with the base lens, with the markings, we'll do a scan to measure what's called an RMS value, or basically the kind of the amount of aberration a patient may suffer from. In this case, the blue bars are prior to HOA correction. So you can see that there's more aberration, and there's kind of one particular one, the coma is up around a 0.3. In our clinic, we have had training from OVITs, and also kind of our clinical experience is that patients that are below a 0.3, you can try it. You're not necessarily, they're not our home run patients that we like to say. Patients that have an RMS of about a 0.34, 0.3 or a 0.4 or higher, and a clear enough cornea, stable lens, are very likely to notice an improvement when you put a HOA correction in. Now, the orange bar, so I want to summarize this in one figure for you so it's not confusing at all, shows the lens after we had applied the HOA correction to the device. And again, that measurement of the optic comes from OVIT's aberrometry over top of the ESP-driven Boston Sight 360 lens. And I love this kind of collaboration. So here we have multi manufacturers working together with all this cool tech to build these lenses. And it's a wonderful partnership. And yeah, it's just a lot of fun to work with different groups to create this beautiful lens. The orange shows a decrease in the aberration to a level that's tolerable for this patient. And I want to give you an idea of kind of what things may look like for a patient before and after the aberrometry correction, or the aberration correction. On the left is a vision simulation based off of our measurement that shows the excessive coma in this case. And this is a really valuable screen that you can pull up and show a patient, because patients love to be validated, honestly, and I do too, personally. Something's really been bothering me for a long time and no one really understands. And in this case, patients who are 20 unhappy sometimes have a hard time explaining to a provider, a vision provider, or somebody else, like, why they're so unhappy. And this is a cool little visual simulation that, I mean, patients not seeing this blurry with everything, but in some lighting, and they do get ghosts that look just like this. And you'd be amazed at what patients, their reaction is when you show them these sort of simulations of what they may see. They say, yes, that hook, that's what I see. And then on the right-hand side, it's a nice education tool to really show, okay, we've tightened that up with your lens with the aberrometry correction on it, or with the aberration correction on it. And it's kind of a nice little visual simulation to show patients kind of before and after, and show clinical success as well. Here is the exact same thing that I just shared with you in written form. So for those of us that prefer to just look at a number, the yellow is the RMS value that I mentioned before of a 0.3. So this is the starting point before the HOA lens, and then a 0.19, which is much more tolerable in the green now for this patient. And his experience was very much that he noticed a large decrease in his kind of glare and ghost at night, especially when he was driving in the dark. So in this case, it was very successful for our patient. Point spread function kind of highlights the same kind of thing. This one's a really fun one to show patients. This is where they really see kind of what their hook or aberration looks like in the dark, and then nice and tight on the right-hand side with the final HOA lens. Here's our final lens, the third lens. So beautiful story, and really, no time spent at all on modifying this shape of this lens, more time spent on educating the patient, making sure that they understand the process, and getting that optic optimized. So those visits were definitely used to the fullest, to kind of leave us with these beautiful lenses, right and left eye, easy peasy, HOA correction, done.
Let's move to the second case I want to share with you today. CH is a 44 years old female, North African origin, immigrated to Canada very recently. She was diagnosed with keratoconus earlier. And as it is the case in those countries where scleral lenses are not so available, I would say, especially in North Africa, the corneal graft is the go-to procedure for keratoconus patients as soon as they are diagnosed, regardless of the evolution, presence of scar, quality of vision, etc. So it's a way for them to treat that condition. And it's okay when you have no other resources, but we are fortunate to have access to scleral and specialty lenses that are widely available in North America, Europe, and many other countries. So we have to deal with these patients who underwent corneal graft. So she did a first eye in 2004, a second eye in 2012, immigrated here in recent years, and obviously in some offices, they don't deal with specialty cases, so they refer the patient to us. We more than happy to welcome them. she had seen a lot of practitioners. Some tried Sclerals in several occasions, but the result was kind of deceiving. She was not able to wear her lenses more than 4 hours a day for most of the fits she had, and or she faced constant touch and high vault over some other parts of the cornea. So it was a difficult fitting process. And for the patient, for the practitioners, I would assume, and she came here with very high expectations, and hopefully that she would be able to help her. Um, because she reported very good vision with clear lenses, and she wanted to restore her vision the most as she can. She wanted to work, she wanted to be active in life, and with her actual vision and actual pair of glasses, that's not the case. She barely can drive, certainly not at night, and then she's not able to read a long time. Computer is problematic for her because she has high myopia, eye astigmatism, irregular astigmatism, of course, as we expect from a corneal graft, 612, 618 as vision, but the vision may be improved because under pinhole we have 6, 7.5, and 6.9 as best potential visual acuity. The cornea the grafts are clear. Sutures are still in place. No no problem really with ocular health so far. So that's a good thing, because sometimes we deal with older patients with old graft that are more fragile, and we know that sterile lenses may trigger hypoxia on corneal graft, and especially if the endo cell count is reduced less than 800 cell, but depending on where the cells are and depending how viable the cells are. So the number is one thing, but you have to look at your endothelial mapping in order to identify the good cells from the bad cells and do the proper count out of that. It may be surprising, some corneas that seems to be really weak will do very well with several lenses. Some other corneas that seems to be very healthy will have a complete failure. I saw graft becoming opaque in a matter of 2 hours after several lens wear. So it happens, and it's a fragile cornea, and we have to look at that. But in that case, I had no concern to start with. And you see the high irregularity of the cornea from the image you are taking. This is the way we do a scan. In that case, that was very easy to have a large scan, which is not the case with all patients, but she responded well. And so habitually for the patient, we ask the patient to pull down the lower lid themselves, and me or one of my student, one of my staff, helped to just lift up the upper lid. In that case, we had a very, very large and decent scan. Important to be in focus all the time, to put a lot of fluorescein, to have a good reflection. And you see from the Mars to the left, this is the first thing I look at. And obviously, the software will provide you with some indices of quality of the image, the focus, all that stuff. But I don't really rely on that. It's useful to have as information. I really look at the maps, and I really look at the image. Am I satisfied with the quality of the image that I have? And if it's not the case, I just retake a second one, a third one, and it's quite easy to do so because you have a button save and take another image, so it's very, very fast because the eye open like this evaporates quite rapidly, and sometimes if the fluorescein is not that present, this is when your image are not from a good quality. So in that case, we confirm the irregular profile. You see on the right side of the cornea all the bulging of the conjunctiva, and from the transition of the cornea to the conjunctiva coming from the tension of the sutures that are still in place. Sutures are also in other places of the cornea, but with less tension in that particular area. They are very tight, and they create a somewhat bulging. And I just, again, from this can I understand why the other sclerals were not successful. If you don't address that kind of particular shape here, especially if you combine this with high depth of the vertical and inferior conjunctiva, you have a surfaces that are very, very low compared to the other surface. So yeah, you may have probably 600, 700 microns of differences here between the lowest and the deepest conjunctiva and the highest one. It's quite impossible if you don't map these surface to determine the exact amount of toricity or the difference in sag from your landing that you will need. The cornea is also irregular, of course, because of the tension in the sutures, and the perilimbal area on the other hand, it's quite symmetric for most of it. So you can have images superposed with the scan. That's a good thing, because it's another thing. Sometimes the eye is just really not well aligned, so you have a mismatch between the map, and it can deteriorate a little bit the information you get from. So it's always a good thing to just make sure that the map represents exactly what you have in front of you and is at the right place in the conjunctiva. Otherwise, you may be misled by what you see on that surface. So again, with that type of cornea, the HVID was 11.8, which is normal, but I selected a larger lens, 17 millimeter, trying to overvault that bulgy surface and to land at a larger area instead of landing near the limbus. I really like the smaller lenses. Habitually, I played a lot with 15.5, 16 millimeter lens. Habitually, it's my go-to diameter, but in that particular case here, I really wanted to be a little bit larger. Prolate, because based on the scan, again, I didn't see a lot of oblate shape at the corneal level, so a prolate design would make the job. And the way to determine the toricity to put really in that lens in order to land nicely in every quadrant, you can just scan and look at how many microns you are in depth or elevated compared to the other ones. But I am also like to play with the software itself. So it will give you the sagittal height along a given chord in a chord length. So dealing with the 17 millimeter lens, I know that in that particular lens, the lens is landing on the conjunctiva. The first point of contact with the eye surface is at 13.6 millimeters. So this is where it matters, and because the rest is just plastic on the conjunctiva, because most of the pressure of the lens will be applied at this 13.6 millimeter diameter. So I evaluate the sag over there at 13.6, and I evaluate also at the limit of my lens at 17 millimeter, and I make the difference between these two sag values, and I determine what is the total amount of toricity and what goes inside and what goes in the periphery. So I can again recalibrate the profile of my lens in the vaulting chamber and also in the periphery of the lens. In that case, the maximum difference at 17 millimeter was 81 microns, and at 13.6, 70.70 microns. So that means the difference between these two of 110 microns. So this is important here, because at 17, I evaluate 800 microns of differences. If I have a regular lens with no bi-elevation, just a regular design, I would have to apply this entire 800 toricity in the periphery themselves. Obviously, my vaulting chamber will be highly irregular, and it may create aberrations and visual issues. Here, I know that my peripheries will be 110 microns toric, and the rest will be put in the vaulting chamber. So again, a bi-elevation applied in that particular cornea. So 500 microns there, 5400 by 5900 with the base curve and the power of minus 1050. We were able to reach a surprising 20/20 vision, because with the pinhole, we noted that it was 6 out 7.5 and 6 out of 9 as the best visual acuity, but pinhole in very irregular cornea is depending on which hole the patient is looking, because if it goes through a very irregular point, even if it's aligning with the macula, it will be slightly reduced. If you go just a little bit beside with the next point, and the patient is looking at that one, you may improve the vision. So you never, it's a good estimate, but it's not the final answer. So when you vault over that with fluid and you compensate for any irregularity of the surface, then you have the perfect optics and you have the optimal vision that you can have. So in that case, a happy 20/20 patient, a lens fitting well, with no discomfort. The patient was able to wear the lens during all day long because it was designed appropriately. So without the eaglet scan, it wouldn't be possible really to minimize the number of lenses tried and a reorder and the number of zits. She experienced that. She saw a lot of practitioners who did trials and errors, like a blind person, not knowing exactly what was going on, certainly not identifying where it matters. In some cases of pterygium, for example, you may create a vaulting just locally over there, but you know exactly where it is. You can not only guess, but you can measure the size and the depth of that surface to vault over, and it's really unique information that can rely to the lab and to make the best lenses possible for the patient. So in that case, successful story and the end of the process, and the patient is us for life now. Okay, third case to share with you. This is a very unique case. This case. Sometimes we're not supposed to be emotionally involved with our patients, but in that case, I had a hard time not to be that sensitive to this young boy of 12 years old I met here. And we will not talk about scleral lenses here because eaglet can certainly help you to design specialty lenses and not only scleral lenses. That's the take-home message from that case. I was asked as an expert in this case because for legal expertise. Patient was supposedly fitted in scleral lenses, and I had to confirm that first. Scleral lenses was really the answer to this problem. Second, the future. For how many years the patient will need scleral lenses, and to establish the cost, the damage, etc., etc. So all the legal procedure on a case. And in fact, the case started during the summer. The boy is an Italian boy living in Italy. So we're coming to Montreal because his mother is original from Quebec. So she is a Quebecer, and the boy is spending almost all his summers here in the province, in the country, with his grandparents. And he was sent to a summer camp for a few weeks, and by accident, he had ocular trauma, branch 3 in the eye. It was an accident that was not well taken care of in the first minutes. In fact, they just washed the eye, close it a bit. He spent the night with that, complaining about pain and tearing, but cold compresses, that was it. And next morning he complained about losing his vision, and then they refer the patient to an optometrist nearby who identify a deep scar, a deep cut in the cornea and the leakage. So the optometrist referred the boy immediately to the ophthalmology department of the Children's Hospital here in Montreal. He was surged in the same day, got suture in the cornea. The cornea was restored. Because of the trauma, the crystalline lens developed a cataract, so he had cataract removal. But because of the debris and all the trauma, it was an cataract where the capsule was also removed, so no option to put an implant in that eye. Vitrectomy was done also. So it's a major surgery for that eye, honestly. And I saw him 1 year and some months later. And the cornea was deeply scarred just in the middle of the visual axis. Obviously, the vision was not good because of that scar. And also the cornea was heavily distorted because of the sutures and the healing process that was involved. He was aphakic, needing obviously a high power lens. And the drama is that this guy was very active in sports before. He was a very good soccer player, and since a year and a half, he didn't play a game because he didn't see well from one eye, and was afraid to hit or to be hit on the second eye. He complained about lens sensitivity, and computer work was challenging for a teenager. It's a drama in itself. Cannot study, cannot play games, video games, cannot chat with his friends really for a long time. So good thing for the visual system, though, not being on screen more than a few minutes. But nowadays it's part of an adolescent life. He was fitted by a colleague in Sclerals. The fit and the vision was defined in the paperwork as good, but the kid was not able to handle the lens, which is the case of a certain number of scleral lens patients, even if they are young or old, age, regardless of the age. Some patients cannot really handle these lenses, open the eye wide enough to apply the lens on the ocular surface, and it took hours for that guy crying. It was a battle with his mother and father, so it was a lot of stress in this family just because of this, and he knew that he had to wear the lens just to restore his vision, because its refraction was 624, and 624 visual acuity. Obviously, he needed also a addition at near, because he has no crystalline lens anymore. So this is the topography of the cornea. You see it's kind of a even regular astigmatism, but it's coming from the scar, and you see the scar from the image of the pentacam on the left, traveling across the central cornea, just in the middle of the visual axis. Just below that, the vision would have been probably not affected, even if the cornea would be distorted. Light sensitivity would have been there, but because the pupil was dilated a bit after the surgery permanently. But in that case, the vision was really lost because of the scar. High order aberrations because of this. You see from the pentacam again in the middle here, you have the spherical aberration at -1050. It's 1,000 microns. Just to put you in perspective, the average eye of a Michaud patient is about 200 microns. So it's 5 times the level of spherical aberration, and we know that spherical aberration will reduce the contrast sensitivity and will pollute the image, will increase the ghosting around the images. And you have vertical and horizontal coma. A vertical coma at 434 and horizontal coma negative spherical aberration of 0.189. So in that case, that these aberrations are coming from the irregularity of the surface, of course, the scars, and certainly doesn't help to improve the vision of the patient. So we did a scan. Obviously, the first thing we did, just to understand better that case. I have very competent colleagues here in Montreal, and the one who fitted that lens, that sort of lens, they mentioned his name. It was obviously in the paperwork, in the papers I received. He's a fabulous practitioner, and I had no doubt that he did everything to have the perfect fit with Scleral lenses. So I wouldn't want to just go with the same scenario, especially looking at the mishandling of that lens from the kid and the drama that causes. So I really thought, okay, we have to go elsewhere, either small gas perm lenses and either hybrid lenses or something like that. But especially when I looked at the scan, when I did the scan with the profilometry with that particular patient, I saw why the lens, even if that was a perfect fit, was not really a good option. Because if you look at the left portion, the temporal portion of that conjunctiva, you see an alignment of red lines. This is not an artifact. This is really the mountains and valleys of the conjunctiva healing after the trauma I received on that eye. And just beside this more elevated portion of 229 microns, we have a sunken conjunctiva of 342 microns in depth. So we have a difference of 600 microns side by side. And so it's quite impossible for a scleral lens, even with a Corrad 1 specific approach, except to get molded lens that can be used in such cases, but again, because of the handling, we didn't want to go with scleral to the exception of if we have nothing working with in other options. But in that case, you will see that we finally had an option. But just because of that, again, looking at a bit, even if I didn't know a single thing about that case before, even if I know knowledge about what happened before, I've had this patient in front of my chair and I look at my options. What are they? So I scan, I do my profilometry, and from there, if I'm considering sclerals, I'll be in trouble, because except if I go with molded lenses and complicated, procedures, I have to go elsewhere. So piggyback, small gas perm, hybrids, and then it clears the option. Again, save my chair time, save time of the patient, number of visits, put the expectations of the patients in perspective of what we can do to improve their condition. So it's very, very useful to scan prior to do anything else. Not only when we have problems and we face problems with devices, nowadays we use the profilometry as the first step to identify where the problems would be and what to expect from that particular surface. What can we do and what is possible to do with that kind of eye. Here we had to restore the corneal profile that is irregular. We have to improve vision if possible. We have to lower the optical aberrations coming from the irregularity. And we have also to protect the other eye with polycarbonate glasses when the kid will be exposed to some sort of, challenging environment. The option for the right eye, I already mentioned the gas perm hybrids or the molded lenses. In that case, we decided to go with the hybrid lenses because it's probably the easiest to manipulate. Piggyback, because of the scar. The small gas perm lenses would have been hard to do not touch the cornea at a given point, even a feather's touch. Otherwise, the lens would have been unstable or too steep, and then would have to would be dislocated inferiorly. So I would have to use most likely a piggyback system with two lenses, with the daily disposable silicone aerogel lens plus a gas perm lens. So a lot of patients don't like to handle two lenses at the time. So that's why we tried first hybrid and then a plan B, piggyback if needed. And we didn't go there because hybrid was successful at the first trial. We were able to reach 20/20. Habitually, I select my base curve according to not the flat key, but the best fit sphere in the case of an irregular cornea like that. And habitually it goes very well. And we align the skirt, to get a decent movement and a good tear exchange on that particular cornea. We ordered a multifocal lens empirically. Said that's a possibility with hybrids. Finally, we tested it and it didn't work because it penalized too much of vision at distance. Multifocal in just one eye is a challenging thing in presbyopic patients, but here exactly the same. So we remain with the single vision option for that particular eye, and we complement with the reading glasses when the kid has to look at computer or read or study or doing like that, and we can protect the other eye with polycarbonate lens at the same time. So we needed glasses anyway, so it is the decision here to go with monofocal lens for the eye and the progressive add lenses for the near vision. So in that particular case, the profilometry help us not only to be successful in our fitting, but to determine in advance what kind of options would be available and certainly suitable for that patient, save a lot of chair time, trials and errors, especially because the patient was living in Europe. I didn't have a lot of time because I saw him when I looking at the report and all that stuff. I said, okay, I really have to look at the patient for also to complement my expertise. And he was in the area at a given point. So for vacation, so I examined him. So I had limited time to refit that patient, and it was successful. I saw him once since then, and he does great. 20/20 vision, and very happy. Resumed doing sports. He's now back to what a normal guy of 13 years old now is supposed to do. And really, this is, I think, a good conclusion for this meeting. with the technology we have, we can do what we have to do. That means change life of every patient in order to improve the quality of life, their vision, and to make them better human being. With that, thank you very much.
Okay, so now we have time for some Q&A. If anybody has a question, you can put it in the chat. But when one question that has come up is when you look at the spectrum of treating keratoconus, and people use different lenses at different stages of keratoconus, how do you know when to move from one type of lens and then move into the scleral lens?
Yeah, that's a good question. So a lot of it just depends on how good a vision you can get with the most simplest approach, right? So how good a vision can you get with glasses? That's not very good. Like what could you get with a soft lens? That's probably not very good with keratoconus. And then you just kind of move up from there. So it also depends on how happy or satisfied they are with slightly reduced vision. Not everybody necessarily, Sheila presented a really great case with the HOA. And I also, do HOA lenses. I know several other people on the call do too. And it's that's a great way to get absolutely maximum vision. But as for as many people who are unhappy with, I think she used the phrase like 20 unhappy. There's plenty of those people. There's actually a surprising amount of people who are 20, 40, and they are happy. So a lot of it just kind of depends on how bothered each particular person is, I guess, by the vision they're getting in their other means. Scleral lenses, though, as far as like comfort, some of that there's practical things, cost, right? Like a corneal lens will serve people very, very well, but some people have had bad experience with them in the past, or maybe for whatever reason they're just they're worried about it coming out, or they're very active, maybe sports or outdoor activities or anything like that, that maybe just wonder if maybe a corneal lens might not work. As far as hybrid lenses, I don't really do hybrid lenses personally, but I know a lot of people do, and they find them very, they like them, so I couldn't really comment too much on that. As far as scleral lenses, for me, I think like a lot of people, with keratoconus, I'll generally kind of just gravitate towards that unless cost is an issue. Maybe they have a particular eyelid anatomy or something that I just think they maybe will struggle. Langis had a great case there where he had a couple of reasons why he might not go that route, but hopefully Ted, that kind of answered your question.
Okay, so somebody else is asking, does the eaglet assess anterior posterior cornea for early keratoconus DX as well, or just for the fit? Thanks.
The eaglet does have a KPI, which is a keratoconus predictive index, is what that stands for. And so KPI is basically a metric that uses multiple other metrics combined into basically a single metric, and then essentially is your percentage likelihood that what you're looking at is keratoconus. So the answer is yes, it does have KPI, which is a very common keratoconus metric. Outside of that, you can do other metrics, which is it's an anterior surface imaging device, so you won't be able to do a posterior corneal or posterior elevation kind of metrics. But there is another metric. Obviously, we know about K-max. That's a very common one. You can kind of figure out K-max on your own. But there is a central K that's anything over 47.2 on your central K, which is basically smack dab in the middle of the cornea, which is different than average K, and it's different than max K, but your central K, anything over 47.2 is abnormal, and anything over 48 is considered keratoconus. You can basically change your maps to either axial and tangential, your corneal elevation. You can change to corneal maps outside of the very traditional bisphere elevation map that we've been showing in these examples. And then you can hover your mouse over that point. So there's a number of ways that you could do keratoconus metrics analysis.
Okay, thank you. That's good. And then somebody asks, I've had some fitters say you should really master one design of scleral and only go to others if need be. Are those with the ESP finding they can master multiple designs more easily?
Yeah, I mean, I'll just keep jumping in, Ted, until
Sure.
Sheila or anybody else has an opinion. But to me, I guess I feel differently. I kind of like using different labs for different reasons, and it can be from how customized do I want the lens to be? Do I want it to be software based or not? You know, I'll be honest. There's factors like what's the hours that they operate, right? I mean, there's just practical considerations. How quickly can I get the lens? Is it a West Coast lab? Is it East Coast labs? Is it central? Like, I'm central, so I like to get my lenses quickly. So there's a lot of reasons why I might use one lab over another for various reasons. And then also, some labs are compatible with certain things like HOA optics. There's other labs that they may be more limited in certain diameters. I've made decisions based on what colors are available in the lenses. Right, some labs will carry more variety in their lens blank stock. So there's a lot of reasons that you would use different labs. The eaglet basically is just because it's an open source platform. You could use one lab and do everything with that one, or you could use a dozen, and it just gives you the freedom to go either direction.
Okay, that's all the questions at the moment. So I think with that, unless something else pops up here, which has not, we can, what one new message? Oh yeah, Elena, my backup from the Netherlands, who's up here, whatever it is, 2 or 3 in the morning in the Netherlands. Thank you, Elena. She is just reminding me that tomorrow we go into the other side of deep and wide, which is OrthoK, corneal GP, and custom soft lenses. So we have some great cases there tomorrow night, same time, same station, 8:30 p.m. So I would just really like to thank our presenters that were presented during this webcast. Dr. Langis, Dr. Morrison, Dr. Wolf. Dr. Wolf, thank you for being here to help us with the questions. And we'll probably see some of you tomorrow night. And with that, we'll sign off. Have a nice evening.